consultants, the ICU people. So it gives you a good idea of TBI, because that's what the topic actually is, was TBI, not subdurals and the SIADH. I thought, why do they want to talk about that? Anyway, it's a TBI talk, okay? So that's what we're talking about. And my understanding of traumatic brain injury, which hopefully, if you understand TBI better, your management is better. Okay, so this is just an introductory slide. Like, it's very common called in South Africa, but you guys know that already. Over 1,000 missions of critical care, you see a lot. So to understand and manage TBI, you can classify TBI in different ways, okay? This classification, which is a kind of pathophysiological classification, helps you understand how it occurs, what the injury is, and consequently what the management can be, and what you can fix and can't fix. So this pathological classification, look, you obviously have mild, moderate, severe, and all other classifications, which is useful. But this is the one I choose to share with, because it gives you an idea of it gives you a better understanding of what happens. So primary injury, you must ask questions if you want, and if I'm going too fast or too slow, tell me. So primary injury happens at the time of the impact. That's what happens as a bullet hits your head, or your head hits the tree, or your car, or whatever. So this primary injury is a moment of impact. It's irreversible as far as we're concerned. In other words, we cannot fix it with our management. There's often some improvement, but it's over time and it's not related to anything that we do. So that's important to understand about it. The primary injury is irreversible and happens at the time of impact. So you can then further divide that into focal or diffuse. So focal would be a brain contusion. Okay, if you got a contusion, you can't fix it and take it away with medical or surgical management, or a laceration from a bullet or a knife or whatever. If you've cut the neurons and the axons, you've cut them. You can't join them together again. And then also, very importantly, the diffuse head injury, okay? The diffuse head injury, what we call mostly diffuse axonal injury, is what happens with acceleration and deceleration injuries. In other words, MVAs, MVA pedestrians, that type of injury where there's sudden acceleration or deceleration in both a linear and a rotational components, and you get diffuse tearing of axons and neurons throughout the brain. There's movement, particularly between the gray and the white matter, because of different densities, and accelerate and decelerate at different velocities, and you get diffuse tearing of axons and neurons throughout the brain. Okay, so it varies. It's a pathological term. In fact, what the pathologists are seen under the microscope, but we tend to use the same name. And it varies in severity from a mild head injury, or like in a rugby injury where you plowed your head into the field, and you've seen that there's sudden deceleration, which is so-called concussion, but it's actually a TBI with a mild diffuse axonal injury, to a very severe one, an MVA where the patient dies. Okay, so that's important to understand. Is there any questions about that? No. Okay, good. All right. So the next thing is secondary injury.
No, thanks. No, thanks, Patrick.
Okay. So the next, you must just stop me if you've got questions. I'll assume you understand everything if you don't stop. Secondary injury, this happens after the initial time of impact, okay? And this is where we come into it. We can prevent the secondary injury often, and we can treat the secondary injury often. The secondary injury, obviously, if it's not treated or prevented, will make the injury much worse. And this is where we come in trauma unit, in ICU, in the surgery and all that. We're treating the secondary injury. So what are secondary injuries? Intracerebral hematomas, okay, subdural, extradural, intracerebral. They don't happen at the time of impact. They might happen shortly thereafter, but an extradural or subdural takes time to happen. So if you have an extradural, a fracture, you have a arterial injury. Actually, I'll discuss them a little bit more, but they did later, so I'm not going to go into it too much. They are secondary injuries. Cerebral ischemia is extremely important. I'll talk about it a little bit. Up to 50% of patients have cerebral ischemia. Cerebral swelling and edema is secondary injury. excitotoxicity, which really means seizures, herniation as well. So those are the main secondary injuries. Infection is also a secondary injury, and there are others, but those are the main ones. Okay, so just to quickly run through it, the extradural hematoma, you can see on the right side what it looks like on a scan. It has a typical appearance, and at the bottom of the screen, you can see what it looks like. That's a post-mortem specimen, obviously. It's a hematoma that forms outside the dura and compresses the dura. And it forms from injury to the middle meningeal artery. So invariably, there's a fracture overlying the middle meningeal artery, and you have an injury to the middle meningeal artery, and it starts pumping arterial blood, and eventually forms a hematoma that has a massive, or has a mass effect, and it can get larger and larger, and eventually you can die. So that's why you say there's a period where you can talk and then you die, because it's taking time for the hematoma to form and have its effect. And the same with the lucid interval. So if you get a patient in who was hit on the head from whatever source, often a focal injury, actually, it is a focal injury, and then they were fine, and then they started getting complaints, headache, sleepy, drowsy, and in a coma, highly suspicious of an extradural. The point is, if you get to this thing early, and you take the hematoma out, and you take the mass effect, it is a focal injury, and you can have a good prognosis. If it takes long, the patients can herniate and die. So secondary injury, acute subdural hematoma, sorry. Acute subdural hematoma is not the same story, okay? So this is often associated with diffuse axonal injury. So the mechanism is normally with acceleration or deceleration. So if you look at the diagram below, if we've got a pointer, you see the brain, you see the bridging veins going into the sagittal sinus where the dura is reflected. Okay, so what happens here is the patient, for example, just involved in an MVA, there's sudden deceleration, there's movement of the brain relative to the sinus, which is fixed to the skull. That bridging vein tears, and you have venous bleeding, and it takes time to accumulate, and there's a venous subdural hematoma. It is associated with diffuse axonal injuries, and often with a burst lobe and other contusions associated with diffuse axonal injury. So the prognosis is determined more by the rest of the injury, but it is poor. So they do have a much worse prognosis than the extradural. The scan, you can see, that's why you can see it looks very different from an extradural. And the post-mortem specimen on the right, you see the dura doesn't have anything on the outside, it looks bluish in color, open it, and there sits the hematoma over the brain. Okay, so that's the subdural. Now, cerebral ischemia, that really is important. A lot of our management in ICU and should be in trauma is related to this. So over 50% of patients will have cerebral ischemia after head injury, and it makes the prognosis much worse. So if you look at that scan on the bottom, that scan is a severe cerebral ischemia that's happened. There's lots of gray-white interface. It's just this ground glass occurrence, and that patient died. So why do you get cerebral ischemia? So you get either from hypoxia. So if the patient's airway isn't controlled, not breathing adequately, they get hypoxia. And then you get hypoxia then of the brain, obviously, and then hypotension. So that's why it's so important to sort out the low blood pressure. It affects the outcome of the brain, because if you've got hypertension, you have cerebral ischemia, that's not corrected, cerebral ischemia, and then you have worsening of the outcome. So obviously the figure that's important, and it only helps if you've got an ICP. So the cerebral fusion pressure is the pressure driving the blood through the brain. We like it to be over 60, 70 is a bit hopeful. We like it to be over 60, and then the brain is not becoming ischemic. And it's a difference between the mean arterial pressure and the intracranial pressure. So what it shows, if the patient's got low blood pressure, you will drop it, the CPP. But if you've got low blood pressure and raised intracranial pressure, it's much worse. So just don't forget about cerebral ischemia. To me, it's almost, after taking hematomas out of that, the most important determinant of head injuries. And we spend a lot of effort and time in the ICU trying to treat it. Okay, then cerebral swelling. So cerebral swelling is not a well cerebral swelling is misconstrued quite a lot, okay? Cerebral swelling is used to refer to everything in the brain. So cerebral swelling, if you've got a head injury, the true cerebral swelling is if you've got a head injury and you lose your autoregulation and you get dilation of the vessels and you get hyperemia, then you get this diffusely swollen brain, okay? And that is cerebral swelling. It's in fact loss of vascular autoregulation, vascular engorgement, hyperemia, and brain swelling of the whole brain where you lose the cisterns and that. There are other types associated with toxins and vascular injuries, but I'm not and hypoxia. I'm not going to discuss that now. I'm discussing this one related to head injury. The second one is in fact extracellular fluid increase. So extracellular fluid increase is fluid loss into interstitial space due to basement membrane breakdown in the vascular structures. So you get leakage of fluid outside from the capillaries and the small blood vessels. And this occurs this is called cerebral edema. So it's increase in water in the interstitial space in the brain from leakage of fluid from the damaged basement membrane in blood vessels. And this occurs around contusions, that black low-density area around contusions. It also occurs around abscesses, around brain tumors, anywhere there's breakdown in the blood-brain barrier. Okay, and that, in fact, we call cerebral edema, and obviously increases the mass effect, causes dysfunction of the area where it's in. And last of all, there's intercellular fluid increase. With damaged head injury, you get breakdown of the sodium potassium pump, and you get swelling of the cells and accumulation of potassium, etc., in the cells, and then they become dysfunctional. And that's at a cellular level. So it's important to know the difference between cerebral swelling and cerebral edema. It's two different things. Cerebral swelling, loss of vascular control, autoregulation, hyperemia. Cerebral edema, increase in interstitial water. Okay, and the last one that's worth talking about is herniation. So everyone knows what herniation is, I'm sure, and you get different types of falcine, transtentorial or uncle, and tonsillar. Tonsillar, you get brainstem compression from the cerebellar tonsils and respiratory motor centers of there, and you have a cardiac arrest and die. Transtentorial, if you get raised pressure supratentorially, you get the medial part of the temporal lobe, which there's a white arrow on the diagram. The uncus, or the medial part temporal lobe, herniates through the tentorial hiatus and compresses the brainstem at the point of the midbrain. And then you get the reticular activating systems there, so you decrease level of consciousness. The motor tracts are there, so you get contralateral hemiparesis. And the third nerve is external, but it runs around the brainstem there, so you get a third nerve palsy on the same side. So that's why you look for the signs of a blown pupil on the same side, and a hemiparesis would be on the opposite side of the lesion. So if you got those clinical signs, the importance of this obviously happens from cerebral edema, subdurals, extradurals, anything that's causing enough raised intracranial pressure. And the herniation leads eventually to death. And if you see the patient's got a decreased level of consciousness, a third nerve palsy, and a hemiparesis, you know the herniation is coming, and then you need to do something quickly. So it's important to look for those signs when you manage either in casualty or in ICU. On a CT scan, you'll also get compression of the PCA artery, so you get a PCA artery infarct, which is in the occipital territory. And we see this not infrequently after extradural has been taken out and it was too long getting to theater. And we see the PCA infarct, and then we know the patient is herniated. Okay, so is there any question on that stuff? Because that to me leads up to the understanding and treating head injuries. If you can understand that, you understand much more what you're doing in head injuries and have an understanding of why you're treating and why. Okay, so when it comes to management, yes? You have a question?
No, Patrick. I think no, that's very clear. Thanks.
Yeah, so that's the most important part of the talk. Right? To understand that, you understand how to treat these things. So obviously then head injury is not one thing, it's a whole spectrum of injury. And it's important to know what happened. Did they get hit on the head with a hammer, which is a focal injury? Were they thrown out of a car, which would most likely be a diffuse axonal injury? It's all important. And I'm not going to go through ABC. So you know if you have to do ABC. Airway for hypoxia. So if you just think about airways for preventing hypoxia. They're not maintaining the airway, you better make sure they've got an airway, or they're going to get secondary hypoxic injury. Breathing the same. They decrease their level of consciousness, not sure of their breathing, ventilate, preventing hypoxia. And then circulation is obviously for preventing hypertension, preventing secondary ischemia. That's why it's so important. And that's why I think the most common secondary injury by far is ischemia, because things aren't done quick enough or well enough. Okay, then obviously look for evidence of injury, coma score, skull fractures, pupil response, limb weakness. You pick up a blown pupil, hemiparesis, decrease in consciousness, you must expedite your scan because there might be extradural that can be treated, for instance. Okay, so coma score, you guys know, I'm not going through that. So what investigations do you do? So skull x-ray. So we don't bother with skull x-rays, and if you've got a CT scan, there's no real point. If it's a smaller hospital and you don't have a scan, it's always worthwhile doing a skull x-ray. Okay, but CT scan, it's no point in doing a skull x-ray, in my opinion, just waste time and resources. So CT scan indications. So when I started, it was a long time ago, to get a scan, you had to have a coma score of like 10. And it was not easy to get. Things have changed. Okay, so if your coma score is not 15, you need a scan. In fact, if you have a history of a loss of consciousness, you need a scan. And then any focal sign, CSF leak, any seizure, any penetrating injury, so you don't get embarrassed by the broken or blade in the frontal lobe, get a scan. Okay, so it's very simple to get a scan. And if a patient has had a head injury or a rugby injury or whatever, and comes on a Monday and is moaning about headaches, get the scan. There might be a contusion, there might be a thin subdural. So a CT scan actually is a drop of the hat. Just at a drop of a hat, get a scan. So the investigations, I'm not going to go
Patrick,
into...
I can maybe I'll
Sorry?
maybe just comment on that, Patrick. I think I'm just saying, our context is, I think the difficulty we have is when a patient's in Beaufort West, to make that call, do you send everyone that's got a headache from Beaufort West and Knysna and Oudtshoorn? So it is
No. Okay. So if a patient's in Beaufort West and the patient's coma score is 13 in 14 out of 15 and there's nothing on the skull x-ray, it's not unreasonable to say, okay, manage them there, do regular glaucoma scores. If they don't improve by the next morning, they must come to you. If they deteriorate, they must come to you. If you've done a skull x-ray and there's any fracture or whatever on the skull x-ray and the coma score is not 15, they must come to you. That's simple. I just didn't include it in there.
Yeah.
So you can tell Beaufort West, if the patient is 13 or 14 out of 15, they can keep him overnight, coma score her, and there's a normal skull x-ray overnight. If a coma score is less than 13, they must come. If they are 13, 14 with abnormal skull x-ray, then they should come. Because the incidence of pathology underlying abnormal fracture is much higher. So, okay, so are you happy with that? We still think too many are coming.
Yeah, no, I think it's difficult one, Patrick. I think, the 13, 14 one are the easier ones. There is the 15 that we oftentimes see, but oftentimes they phone us 2 days later. They said, yeah, he was 15, then he comes back, and then,
If he's
then
got
they got focal
persistent symptoms, he must come as well, but that's only going to be down the line. That has to be a few days. So if he was 15 and he comes back and he's got bad headaches, then the correct thing to do, in my opinion, is to get a scan. And if I come to the other part of this, what I'd say at the end of the talk, actually, but you need to exclude the extradural sitting there, the subdural sitting there, the contusion sitting there. So if they've got persistent symptoms, then I think you need to scan them. So what do you mean by persistent? By 15, they get sent home, they come back moaning. It might well be they've got post-concussion syndrome, which case is normal
Yeah.
scan. You don't know that till you've done the scan.
I think the complexity is just sending a patient for 4 hours with the only ambulance. I think that's where it gets quite difficult for the guys in the district hospitals
Yeah,
to
no,
know
I
which ones
understand the
to send.
problem. It's not, yeah, it's not the void, but if you're having persistent bad headaches and stuff, then I think, you know, if you send them for a scan, the scan is normal, it's not a waste of time scan, because then it's easy to manage the patient.
Yeah.
They might be having, and they often have persistent things. I'll tell you, but if they're having persistent symptoms, 48 hours afterwards, I'd seriously consider sending them for a scan. They don't necessarily have to come as emergency in the next available ambulance, but they need a scan, in my opinion. So my attitude is everywhere, most places in Western Cape, what the furthest away is probably 4 hours from the scan, by ambulance. And the ambulance, you don't have to bring them flashing lights. They can climb in the ambulance if there's one coming in 5 hours' time for other things. So you got to weigh up everything. You know, it's not so simple. But that's the easy structured approach, to put it that way. What do you think? Difficult.
No, I hear you, Patrick. I think we always navigate. I think the difficulty is the ones that they don't call us for, and then
Yeah,
they
but if
call
they
us
don't
2
call
days
you, then you
later.
can't do anything about. Then it's not your
Yeah.
issue. You can't
Yeah.
be guilty for everyone.
Yeah,
But
no,
you
I
tell
know.
them if he has persistent ongoing symptoms, he probably should have a scan. Look, yeah,
Yeah, I agree with you.
yeah. Okay, so anyway, these are the other tests you do. The important thing I'm going to just say is do a cervical spine if there's a head injury. There's a relatively high incidence of cervical injuries. If you do a scan, you do both at the same time. So, but if you're not going to do a scan, it's not unreasonable. And the patient, you know, is MVA. If they're 15 and they say, look, I've got no neck pain, move their necks around fine, and no tennis, that's fine. But if they're not 15 and they had a head injury, the C-spine X-ray is not a good thing to do, to exclude it. Okay. So now comes the treatment. So this is so there's different parts to treatment. So this is just what we do. If there's a hematoma, we do a craniotomy, which everyone knows, take off the bone, take the hematoma out, put back the bone. If there's a depressed skull fracture, we do a craniotomy, which is elevation and removal of the broken fragments. And then from my perspective, or the ICU perspective, you try and maintain the CPP by maintaining adequate blood pressure and lowering the intracranial pressure. So your management is aimed.
Patrick, can I ask just,
Yes.
we get a lot of skull fractures. So what are your, I mean, I think from our point is those skull fractures, if you're saying depressed, what do you mean by that? Because there's a little bit depressed, a medium
I'm
depressed.
going to talk to you about depressed skull fractures briefly. Do you want me to
Okay.
say depressed? So compound depressed is different to depressed. Let me get to the skull fractures. You'll understand more there, because I'm actually going to talk about them.
Yeah.
Which need what? Can you wait? I'm going to get to them at further on.
I can wait.
Okay. So this is what we do for monitoring in my unit. Okay, it's a lot more than most of the units in the country, but there are other people who do other things as well. So we always have an A-line, we always have an ICP monitor, we always have a Lycox monitor, except in certain instances. I put a continuous EEG on only to see if the pressure is raised. I look at the EEG, see if they're having a seizure, because it just rules it out. And it's an anterior montage, easy to read, continuous one. It's not for clever people, it's for us in the ICU. It's not 16 leads, and you can teach nurses to read it. So it's useful only really to say, this patient has raised pressure, it's gone up to 40, and he's having a seizure, that's the cause. Then I'll also look at the ICP waveform on the pressure monitor, which I find very useful. And you look at, I can't really give you a whole talk on it today, you look at the P1 and P2 waves. So normally the P1 wave is above the P2 wave. If the P2 wave is above the P1 wave, it means there's decreased compliance of the brain. So the brain's not happy. So So I've got a patient at the moment, his pressures went up to 24, 25, but his P1 wave was bigger than the P2 wave. So it was more likely because he's awake and the brain hadn't lost compliance. So when it loses compliance, the brain is in trouble and the compliance has almost run out and they're going to cone if you don't treat the intracranial pressure. It also tells you what if the pressure is at 16 and it's normal and the P2 is much higher than the P1, there's a lot more space, less space in this brain to take more intracranial pressure. And it's more likely if the pressure goes up to cone and have ischemic problems, etc. So I look at all those things together. And the last thing is a CO2 monitor, which looks at the expired CO2. Okay, it means I can just look at the thing if the pressure's up and I say, well, the CO2 is running at 6. Let's ventilate him a bit more, and often it will come down. It's not as accurate as a gas. It's normally a bit lower the reading because it's reading expired CO2 from the lung. It's not reading it in the blood. But it's very useful to have. So I look at all those things and I develop a picture in my mind what's going on. So a lot of stuff. All of it gives a little bit of information and it helps a lot. I'm not going to go into more detail, but it's very useful. The multimodality stuff to see what's going on in the brain. Okay, so last time I spoke to you, I actually think I started with this. I don't know if you guys want to go over this exactly how we manage. I can do it very quickly, or I can just leave it out because actually I discussed this last time. What do you want?
I think it's fine, Patrick. I think we can skip that because we can always go
I did
back
it last time with you. The only thing that I want to just say is the most simple thing. Keep the head elevated. Keep it in a neutral position in all your head injuries because it makes a big difference. You got to monitor and you can see the difference. So every head injury, whether you got monitors or not, yeah. So I'm not going to go through that because that's what I did last time. Okay, so then I'll get on to anticonvulsants. So who do you put the patient, who goes on to anticonvulsants? So the most commonly used ones are epinephrine and sodium valproate, except you shouldn't use a sodium valproate in a female who still has a reproductive ability because it causes congenital abnormalities. So if I have to use for some reason, I'll do a pregnancy test first. And sometimes I'll come in the morning and some Einstein at night put them on, a woman 36. And so then I'll do a pregnancy test. The other one we use is Keppra. I don't know if that's available to you. We only have the oral thing. It's used a lot overseas now because it has less side effects. So epinephrine is an old drug. Sodium valproate has issues, especially in females. And Keppra has less issues. So a lot of people are using Keppra as first line in the anticonvulsant. So who do you put it on? Put on a patient who has had 2 seizures. By 2 seizures, as definition, they're epileptic. They have to stay on treatment. Well, it's variable, but for a year. And I take my thing from England because they have a rule you can't drive until you've had seizure-free for a year. So if you're on treatment, you don't have seizures for a year, then maybe you can take them off. So it's, in other words, it's long-term, okay? So everyone else, we give prophylactic anticonvulsants. And invariably I give, if the patient's in the ICU or lying in a ward, I start with phenytoin because it's easy to give 1.2 loading dose. And I run it IV, 100 milligrams 8 hourly for 3 to 4 days when I expect the pressure to be high. This isn't a severely head injured person. You can go to oral much earlier if it's not. And then I stop it after 7 days because it's prophylactic. It doesn't prevent epilepsy. It only, the reason we're giving it is if you have a seizure, you raise intracranial pressure a lot. So if you already have raised intracranial pressure on the Lycox, if you have a mass lesion, if you have midline shift, and then you have a fit, you can push the person over the edge and they can herniate. And so you only need to carry on with those anticonvulsants for the time you think the pressure is going to be elevated. And by a week, it's not normally elevated with head injuries, and then you can stop. So what I find that people forget to stop it, and then 6 months later, the course cockadoo still on his prophylactic phenytoin, never having had a seizure and enjoying all the side effects. So just remember, if you're using it prophylactically, stop it 7 to 10 days later. There we are now. This is your favorite topic. So compound depressed skull fractures. So there are three indications, okay? Cosmetic. If someone has been bashed on the frontal bone on their forehead and has a depression, it's very ugly. So then you can operate for cosmetic reasons. But this is not urgent. This can happen when there's time. It can happen a week later or whenever. It's not, but it is one of the indications. The second one is for mass effect. You know, when you have these patients who've had one of those big brick thing, concrete bricks dropped on the head or a rock dropped on the head, the whole head is stoved in. Okay, because the whole head is stoved in, it's having mass effect, no different to an extradural and a subdural. So you have to relieve that mass effect, okay? So therefore we have to like remove the bone or elevate the bone to take away the mass effect. That's not as common, but 95% is for sepsis, okay? So this is a guy that was hit with a kerry or panga or whatever, gunshot, even tangential. And the reason you're operating, it's compound and it's depressed and there's been stuff driven in, pieces of hair, pieces of beanie, pieces of skin and chocho and sand and whatever else has been driven into the brain. And the risk of this is a subdural empyema or a brain abscess, which has a poor prognosis. So what you're trying to do is prevent sepsis. So any of these dirty compound wounds, if a wound has been got clean with a knife and is compound, we won't necessarily elevate it if it's not severely depressed. But if it's a dirty wound, if it's with an axe, actually that can be clean sometime. If it's with a brick or a panga, we always elevate it because there's always stuff driven in, okay? So you're trying to prevent the sepsis. Now, people talk about, I know this is what you want to know, is people talk about, okay, well, when you elevate it. So if it's a dirty wound and it's compound, just go and clean out the fracture, okay? This full table thickness, less than full table thickness, is a dura torn. If a dura torn is torn and there's evidence like intracranial air, then the chance of meningitis and that is much higher. So you probably should elevate the bone and clean out the wound. If it's greater than full table thickness and it's not on a part of the brain, even that we think it's a problem and there's no, and it's a clean wound or there's no wound, then there's an argument not to elevate it and not to rush into theatre to elevate it. But you can obviously speak to the neurosurgeons, and it depends a bit on their mood sometimes, but they might or might not decide that it's worth doing. Does that help you? Nelis? Nelis?
Hi, Patrick. It does help, but I must
tell
be
me
honest.
what your issues are, and I'll try to address them.
Yeah, it seems like the skull fractures, the acceptance is really dependent on where the moon is or how the wind is blowing.
I told you, I said something
some...
about the mood. I can't change that. I'm not going to go into what happens in the neurosurgery department. I can't change that. It depends on the consultant. It depends, and even with the subdurals, like there's stuff that's sucked out that I've never heard of before. So, and then that's for the month, and that's how it stays. So that's why I'm telling you,
and I think
accept the things I've told you. If a neurosurgeon must send it to do a craniectomy, just send it. But in general, cosmetics, no rush, which is very rare. Mass effect is much more urgent if there's a big mass effect. Sepsis is any compound dirty wound, especially with a brick or a panga, needs treatment, generally.
Yeah, so I think this is the difficulty, is that the wound is being managed at the local level, or we've washed the wound out.
Yes, it's always that problem.
Then sometimes the neurosurgeons will say, "Oh, you guys washed it out. The wound looks good. It's already sutured by the time they get to us from a peripheral
that's
hospital."
often that's the same when it comes to critical care normally, unless it's direct.
Yeah. And I think we also can't send every single skull fracture with an open wound to critical care.
No,
we
so
just
if
don't
it's a
have
brick,
the
it must
capacity.
definitely come. If it's a panga, it must come. If it's a clean wound and it hasn't got tatty edges like an incised wound, then there's much less reason for it to come, because the reason you're operating on those is infection.
And can I ask a question just about
Yeah.
if it's not coming to you, do we give
It
prophylactic
never comes to me.
antibiotic?
I'm in ICU. It only comes to me if the head's been blown off.
Okay, sorry. So I mean,
Yeah, I know what you mean. That yeah. What do you think you should do with it?
Would you always? Yeah. So say the neurosurgeons say, "Oh, you did such a good job. You washed it out." Would you recommend we give prophylactic antibiotic?
No. No, I don't recommend that. If you've done it
Okay.
yourself and washed it out, I don't think prophylactic antibiotic is going to sort out the pieces of bone and stuff in there. If the bugs are already in there, you have little bone sequestra, they're going to hide in there. So get it, wash it out very well. If it's you guys doing it, which I know it isn't, but then it's probably worthwhile keeping the patients for a couple of days in hospital, whether it's you or in Beaufort West or Oudtshoorn, just so they're
Yeah,
not.
I think the difficulty is just I can't vouch for how it was washed out in all the other hospitals. So
No,
that now it's
that's the
already
same
set.
problem we have here. If you
Yeah.
don't,
So I don't know.
it's not totally wrong to reopen it and wash it again. Sometimes they do that here. If it looks like it's a real shitty job, then just open it and wash it out properly. I mean, I know you probably do give
Yeah,
antibiotics, but I don't recommend it.
yeah, I don't know. I must say, I'm more inclined to say, listen, just give antibiotics because I mean I can't open up every single wound that comes from district hospitals.
No,
We got
God.
4 or 5 district hospitals that refer head injuries to us,
So what
so it
antibiotics are you
does
going to
get
give
quite
them?
complicated.
What antibiotics
So
are
I
you?
just give it comoxiclav. I know it doesn't cross the blood-brain barrier, but then also there
Yeah,
isn't
but you're not
an
treating the blood-brain
equivalent.
barrier, instead you're treating the wound. Yeah, that's why I
Yeah,
say
no,
if
no,
you're
no,
going
yeah,
to
yeah.
give an antibiotic, you should give IV Kevsol, because what you're fighting is staph. That's the most common one. It penetrates. It's actually been shown to penetrate the brain better than cloxacillin. It's very effective. It's more effective actually in treating staph than cloxacillin. This is hot off the press new stuff. And so if you're going
Okay.
to give it, that's actually what you should be giving. But
But then you're committing
if the
in
patient's
inpatient
going back to
management.
Beaufort West and you give comoxiclav, I'm not criticizing that. I think it's not unreasonable. All of these things, easy for me to say if I'm admitting the patient here and I'm watching the patient. If you're not watching the patient, you weren't sure exactly how they cleaned it up, I'm not going to criticize that. At least it's going to help wound sepsis, or prevent it maybe. And then if you give it prophylactically, for how many days? Because
I usually give 5 days, but
so that's not prophylactic. Then it's treatment. But also, I'm not going to criticize that too much because I understand why you're doing it.
yeah.
No, it's not unreasonable. I don't think it's unreasonable.
Yeah.
People.
I mean, a good example is, I mean, we had a patient, a previous patient that was organ donated. He basically had the smallest of little wounds at the back of his head. And on the CT, we didn't see a skull fracture, but on the post-mortem, there was a hairline fracture there. And he ended up getting meningitis and died from it.
Yeah, so he had an
Sorry?
implantation. He had an implantation with the knife. So I'm not sure anything prevented that. But if you got a wound and you're happy and you want to put them on comoxiclav because you're sending them back to Beaufort West, hey, I'm not going to criticize that. How many times have you used comoxiclav on yourself when you shouldn't? Probably. I have.
I hear you.
No, so I don't think it's bad practice, but I can't really give you figures to say you should be doing that, but I understand why you're doing it, and I can't say it's wrong, and I wouldn't attack you for doing it.
Yeah, yeah. Okay,
so if
thanks.
you're doing that, then you're happy, but don't call it prophylaxis because it's not. Prophylaxis is 1 to 3. After that, it's treatment. But whatever, you treat.
Okay.
Yeah. Okay. You happy with that?
Yeah, thanks. I'll have a bit of a think.
No, you don't have to think too much. I don't think it's wrong to give them. I understand exactly why you are. They're going back to their little Hondok they live in. They probably won't have follow-up. It's Comoxiclav is going to take out the
Yeah.
staph, which is the big problem.
Yeah,
So I
yeah.
wouldn't worry. You can think about it, and you're welcome to phone me if you want to anytime, or send me a picture, and I'll tell you what I think. But
Yeah,
I wouldn't stress too much about it, to be honest.
yeah. Okay,
You
well,
have been
thanks.
giving it, and you got a good reason. And yes, there's not 20 scientific papers. I don't think it's necessarily bad, but then don't pretend it's prophylaxis. You're treating something.
Mm.
Yeah. Okay. Shall we move on?
Yeah, let's move on.
Okay. So base of skull fractures. I don't know what you're going to say about this, but so clinically, obviously, you guys know all these signs, but mostly it's otorrhea. Of the obvious danger is meningitis. So the majority, Darlene and I from ENT used to repair a lot of these things if they carried on leaking. We did so many endoscopically. So the majority will stop within the first week. So they never need surgical treatment. If it carries on, then or if they get recurrent meningitis, then, or if we think it's such a big hole, it's never going to stop, we'll treat it. Normally endoscopically, but anterocranial fossa repair also is okay, and ENT sometimes do petrosectomy for middle fossas. The question is prophylactic antibiotics. So we always give Pneumovac, but that's not going to prevent the sepsis now or prevent the meningitis. It takes 3 weeks to work. So later onset, we don't give prophylactic antibiotics. There's no literature that shows it prevents meningitis, number one. And number two, if you give it, which normally would be ceftriaxone, in the hospital environment, you just seek out a more resistant organism. So you're going to tell me the other guy, if he'd got it, wouldn't have got meningitis, but yeah, it's probably true. But that's
Yeah, I think,
base fractures. I think I've got a much stronger.
yeah, I think we had a. Sorry, Patrick. I think our previous organ donation actually was a similar sinus. Our 3 organ donations back was a sinus fracture. I think it was a frontal bone fracture and then developed a meningitis, and then ended up being, brain dead and organ donator.
Okay, but I'm telling you, it wouldn't have prevented it. It would have just sought out a more ugly.
Yeah.
Maybe not in that individual.
Yeah, I think that was our conclusion also.
Yeah, so I wouldn't give it. I feel less strongly about you giving Comoxiclav to a depressed skull fracture goes back to Beaufort West. I understand that fully. Giving ceftriaxone, you have to give it IV. Then you must keep the guy in. You must give him a full course for meningitis. 10 days at least. Every skull base fracture. Good luck to you. But having said that, having said that, if there's an ongoing CSF leak, you cannot send them home. They must stay in a hospital until the leak is stopped. If you think there's a big deficit, then you must send a CT picture to the neurosurgeons to see if they think it's worth fixing it because it's big and it's not going to stop easy. So sometimes they stop if there's a big opening because a plug of brain fills the defect, and then meningitis comes. It's only not leaking because it's plugged by brain. So yeah, if there's a big defect, send the pictures and let the neurosurgeons look at it. But I'd give Pneumovac to all of them. How long later?
Yeah, I think that.
How long later did the one with the sinus get the meningitis?
How long after the injury?
Yeah.
No, I think it was by day 4 or 5, so the Pneumovac wouldn't have made a difference.
Yeah,
I think it was right about there.
No, it wouldn't have. And quite frankly, I'm not sure antibiotics would have as well. What, did he go home?
No, he went to the morgue. It was an organ donator.
No, I mean before he became that. Was he in the ward still? Or did he go home and then come back?
No, I think he was treated and went home and then came back 4 days later with like a meningitis.
Yeah. So how would you prevent that if he's gone home with giving what antibiotics? So you need to give ceftriaxone or
No.
Derapenem, basically. So you're not going to prevent it by that by giving
No, I
comoxicillin.
think,
Although I must say, they get the maxillofacial people give augmentin for facial fractures, but that's not for
they
meningitis.
do.
That's I've spoken to
Yeah.
them about that.
Yeah.
It's difficult to quote one case though, because everyone has got that. I
That's true.
had died 6 hours from meningitis after post-fossa decompression long ago.
Sure.
Now, how would the fuck I prevented that? So it happens, but it doesn't mean that you must do it. So the best evidence is no prophylaxis for CSF leaks because you don't decrease the meningitis, you just select out a more resistant organism.
Okay.
That's the last word on that one. Okay, recovery. So TBI, recovery depends on the coma score after resuscitation. Obviously, in a deep coma is worse prognosis than if you mild head injury. How long is a post-traumatic amnesia? If you're playing a rugby game and you can't remember the second half, that happened to me a few times, you have a good prognosis compared to the guy who can't remember 4 weeks after the accident. Focal injuries generally have a better outcome than diffuse injury, and age. The old people like me sadly don't do well. They just don't recover as well. And then there's obviously a Glasgow outcome score that you can use. Okay, so this is the last slide. What I wanted to talk to you. So this is the patient who has a head injury, normally a minor head injury or rugby or hockey or whatever sporting injury. They often they won't always have had a scan. They might have had a scan, and which might be normal, and then they have concussion, and then they come back with headaches and dizziness. They can't concentrate. They're feeling depressed and tired and just not cool. So if they come back with these symptoms, they haven't had a scan, you should still do a scan then to make sure there's not an underlying brain injury that you can see, like a contusion or whatever. But otherwise, you say, listen, this is post-concussion syndrome. This is common after head injury. It will get better. It takes time. It varies in time from a couple of weeks to a couple of months, but it always gets better. And if they're about to write the exam, then you can book them off the exam because it's a real thing. And they can't concentrate on the exam or to study. So don't forget about post-concussion syndrome. It's a real, so these are the patients maybe that come back after a week and are moaning about headaches. So to Beaufort West. And then, you might say, look, if you don't do a scan and you say, look, you've got post-concussion syndrome, it will get better. These are normal symptoms. And just, you must encourage them, they will get better. I think that's the last slide. It's the end of the story. This Neurology and Neurosurgery Illustrates, actually a very good book. I use it for my final exams. So if you got one, it's worth reading the stuff up in it if you need to, rather than going to Yeoman's in 300 pages on extrajurals, none of which you understand because I never do. Anyway, so that's it. Are there any questions?
So Patrick, I'll answer you first.
I can't fix your baby. I can't answer baby questions.
No, she doesn't need any neurosurgical intervention. Thank you.
No, or any questions about the baby. I don't mean
Oh, no, Shan. No, she's doing fine. I probably should have asked this a bit earlier, but I had a patient probably 10 years ago and it still haunts me. A young boy with an extradural hemorrhage. And so it says walk, talk, and die people. Are there any subtle signs that we should be looking out for?
No, not really. So if the patient if the patient comes to me, you do a skull X-ray. He's got a fracture in the temporal region, which will go through the middle meningeal. He's got really bad headaches. In my opinion, that's a good enough reason to scan the patient. And even without a loss of consciousness, but with a skull fracture and bad headaches, That is what you're trying to rule out, is the extradural, because the skull fracture will lead to the extradural, and bad headaches is the beginning. Some guys present with extradural
Okay.
days later because they started with bad headaches. Sometimes
Okay.
they got a big lesion, they come 4 days later and it's only headaches. So, but the danger obviously is the mass effect gets
Yeah.
worse and worse, is underlying edema that coma and die. So I think there's not subtle, clever signs, but
Okay.
I think if you've got a really bad headache after head injury, and even worse if you've got a linear fracture, then you must get a scan.
And then how safe are these patients to transport? Or are these the guys we should just basically bury in George?
Extradurals.
Yeah.
Burl's not going to fix the extradural well. Like I know
craniotomy. Yeah.
No, so I think so. If the patient,
Yeah.
so that's slightly difficult. So if the patient's
Yeah.
clinically well, there's a stronger argument. Relatively well, 15 out of 15. If they're deteriorating and they get a blown pupil, there's no doubt it's better done in George, because we will get them at the end here and we'll say, what's a DOA, or they'll have coned and they won't improve. So I think this is the type of person that you don't have to do a craniotomy. If it's life-saving and you had your scan, you know where it is, you do a flap and you do a craniectomy. And then even if you don't get all the clot out, then at least it's a decompression by taking the bone away at least. There are problems you can have. It can be sometimes quite difficult to stop the bleeding if it's coming from quite far down the temporal bone and foramen spinosum. And you have to use bone wax and that, but it can be a bit scary. Normally the bleeding stops though. So I do think that if you got guys that are happy to do a big craniectomy, and it's obvious what the clot is, you just take the clot out and then you're done. So I think there's a stronger argument to do those patients there, because if you send them on an ambulance, well, the ambulance and the airplane takes the same time anyway, by the time it's done.
Yeah.
There's that risk that 6 hours or whatever it is, they can die. If the patient's got an extradural, it's not massive, but you should speak to the neurosurgeons here about it. If the extradural is not massive, the patient's got a headache, there's a much bigger, it's much higher, less risk to send them. If they deteriorated or blown up pupil, they'll be dead when they get there. And it's a lesion. So I don't know who's doing them, but I know you do them sometimes.
I think they just do burls. I'm not sure if that. I think there was maybe a talk about.
Yeah, I don't think burls are enough. Maybe sometimes a burl is better than nothing.
Yeah, no, Patrick,
Sorry?
Yeah, Patrick, they do, mostly they do craniectomies and so forth, because we're doing so many, so I think most of the surgeons are happy to do limited craniectomies.
So that's an absolute life-saving procedure.
Yeah.
And if you get it's not hard to do a bone flap, but you know what, if you're not sure how to do it and you just need to get the bone off, just one burl and nibble, but you nibble around all the clot, take the clot out, make sure it's not bleeding. If you want, you can even leave a drain in and close it.
Yeah.
That's a life-saving procedure. I think that type of thing, I think if surgeons are happy to do it, maybe you have to speak to neurosurgeons here first and say there's someone happy to do it, then I'll do it. I'd also get a friendly
I think I've got
to come work with you.
I've got a question about prognostication.
What question have you
Patrick,
got?
I've just got a question about prognostication of head injuries. I'll just give you an example. We had a patient probably, I think 5 years ago. He was in a motorcycle accident, and he had bilateral subdurals with a GCS, I think of 5 on presentation, bilaterally blown pupils. And we were like, oh, should you not, his prognosis is not going to be great. So eventually we went to theater for a burr hole / craniectomy. And now I saw him last week, and he's, talking, not normally. He's driving his car. He's playing with his children. And, his scan looked terrible. And then there are some other patients where the scan doesn't look that bad, but they're
Well, it's
terrible.
a diffuse head injury.
And
That's a diffuse head injuries for you. Scan can look normal and
yeah,
be vegetative. Yeah, you got to. It's look.
and I think the question is just, how, which patients do we give a fair go, and how long is long enough? So like 2 days in ICU with no improvement, 3 days, where do we draw a line and just say, look, we've given you like 48 hours or 72 hours, now you're going to the ward, and that's it.
Yeah, so there's no easy answer to that. So let me tell you my story was it last week? So anyway, it wasn't a head injury, it was other stuff. But she came from the ward with renal failure, and I thought she had aspirated she had probably a hypoxic injury. She sits here for about 3 days, does zero. She actually had a prolactinoma, but anyway, that's we're treating. And then had a discussion with the family, and I said, look, blah, blah, blah. She's in her 50s, not going to do well. I want you to go home and discuss it and with everyone tomorrow, because I always give them a 24 hours to discuss it. But I think we must probably palliate it. So that afternoon, I got home, I walk around, I checked, following me with the eyes. So the long story short is I tried very hard. That afternoon, I thought, well, maybe she bays down again. And then the next morning on the ward line, I showed her she's bad. I went to the family, I said, no, we're not palliating anymore. We're carrying on. So the point is, what I'm just trying to say is it's difficult to know, even if you've got a lot of experience. So the easy way is just to keep everyone for a long time. So if I'm going to write off a patient, that's what they do in private. I promise you, they'll treat subarachnoids for months. They can be dead. They'll carry on treating them because they feel he did everything, So I think I don't think you must take that whole thing on yourself to decide that. If you start treating a patient, I think you should discuss it. You can discuss with me in neurointensive care. You can discuss with the neurosurgeons. I don't think you should make those decisions alone because they're very difficult decisions. And the other thing is I always, if the patient's in ICU, the first day, if I can, I have a long talk to the family about saying how bad things are, life and death. And so when you tell them, actually, it looks like it's death, they said, okay, you did tell us this could happen. If you don't speak to them and then suddenly it's death, then they're pissed off because it's your fault. So there's not one thing that you can use. So I try to use as many things as possible. So I look at the coma score and all that, obviously, and the non-improvement. And I sometimes can do that in a couple of days, but if you're going to, I think it's reasonable to say you should just do at least 5 days and sort out everything you can sort out. Then I will often do a second CT scan to see this infarct or whatever. And then you can't do it, but I do an EEG as well to make sure there's not seizures, but actually to mostly show the slow waves, which show there's severe injury here. And you can tell in most patients. So patients it's not like they won't improve after that, but to a functional level, so a lot of them will improve to a level where they're still just lying in a bed, non-functional, and they have actually a huge burden to their family. But I think you shouldn't take those decisions. Okay, the easy answer to this, it's multi things. You look at every possible thing. It's different for different patients. What type of injury they had. If it was a focal injury, I'd be much harder or take much longer to pull out. If it's a motor vehicle accident with contusions everywhere and a burst lobe and diffuse axonal injury, I won't take nearly as long. And I think you can consult with other people. You mustn't take a decision on yourself. It's like a big burden, especially if I know you've got a lot of experience, but you're not neurosurgically trained. And, you don't want to stand in a court and say, are you a neurosurgeon? No, I'm not. Well, how could you tell? There is a medical legal aspect to it as well. There is. So I think...
I think our difficulty is just the burden on ICU. If you say, well, let's give him 5 days, that's a massive burden on a 6-bedded ICU for the whole of the summer.
I've got a 6-bedded ICU, and it's a huge burden. You get stuck with the same patients you don't think are going to do well. I know that.
Yeah.
But you can't.
I'm going to call you next time.
Because you got another one. Is he going to do? Which one's going to do better? Toss one. You can't do that. If they're in, they're in. And then you can, I think it's reasonable to make a decision but you mustn't just do it alone. You're welcome to phone me and I'll look at the pictures with you, discuss it, and all the surgery guys. You know, you must get someone else's opinion as well. I think it's a little bit too much. So when you have those Monday, Wednesday, or Friday, I go to Tigerberg I go around Tigerberg's near RC on a Friday with it. But on the other days, that's what you discuss on those ICU meetings. That's what you must discuss. You know, Costello's down there.
Yeah, no, that's helpful, Patrick. I think. Yeah, no, it's helpful. I think it is in the end of the day, we can't make all the decisions just by ourselves.
No, you mustn't. It's ridiculous. It's like me making decisions on other stuff. It's you need to have someone to help you, because and you can look at it like, yes, they're supporting me, or yes, it's another opinion, but it makes a difference. And it's never wrong to get another opinion. And you have a Monday, Wednesday, and Friday another opinion. So I think those cases, you should bring them up there. That's an easy way. Bring them up, say, listen, I don't know if we should carry on with this patient, and it gets at least discussed with other people who are managing the same problem.
No, thanks, Patrick. I think we'll do that. I think we just don't get.
You can always have special requests for Patrick, because I only go down there if they ask me, or if I see there are lots of neurosurgery or head injury problems, then I'll go down there.
Yeah.
But the rest of the time, I don't come to look at the other stuff. So, but
yeah, no, thanks. Appreciate it.
They will often call me if there's something like that. And I think for you, if you're not sure about transferring a patient, speak to neurosurgeons, okay, about acute injury. If you're not sure about pulling out, speak to us on a Monday, Wednesday, and Friday, because you can get good insight. And if you're not sure about the management of a severe injury, then you can speak to me. Just tell me.
No, I appreciate that. Thanks.
No, I'm not one of those guys that could care if I'm phoned. No. Takes me 2 minutes.
Yeah. I think the advice, the advice from neurosurgery is more like they just tell us the patient should stay with you or come to us, and then we don't get that much advice.
No, but you see, they're not even sure the registrar. So they will often they will say, have the patient, keep it there, then they'll show it at the meeting in the morning. And it depends a little bit who's there and what we're there. Don't repeat that. But it does. And then they just get the registrar, phone them back and say it must stay there. But then you should say, listen, okay, we're happy to keep it. What do you want us to do? Is there any advice you can give us? Because they will give you advice if you ask, I'm sure. I mean, the registrars are actually nice guys. I pay them a lot for the exams, so I know them, and they all come through there. So a bunch of registrars at the moment, they're quite nice guys. And some of the consultants are very nice guys too. You know? So,
well, thank you, Patrick. Appreciate your time. I think it's a really good talk, and I think it's good to get advice from you.
I hope you enjoyed it. I hope
we did. Yeah, thank you.
Cool. I'm glad I did it now. It was a much better time than 3 o'clock. 3 o'clock was scary.
Yeah, perfect. All right. Well, Patrick, thanks for your time. Really appreciate it.
No, absolutely.